Welcome, everyone, to the next edition of our panel discussions. We started in March. The Center for Healthy Maryland started doing some initiatives that are around some hot topics, unfortunately, in America right now. Some words that should all be normalized, but aren't. So with our March event, we had Empowering Excellence, and we did a focus on Black physicians and the future of healthcare. This one, in recognition of Mental Health Awareness Month, is a focus on mental health in all of the Center for Healthy Maryland's programs. So the three programs that the center operates are one, dealing with physician health. And I kind of say we are heal the healers is who we are. We make sure that physicians get the help they need. When it comes, whether it's towards stress, burnout, mental illness, substance abuse, anything like that. That's what that program offers, which is a phenomenal program. Another is the Maryland Healthcare Coalition, which two of our panel members, both Audrey Bergin and Dougherty, are a part of. And they help train and teach physicians across Maryland what questions or what to look for or what to ask patients that might be coming in to uncover possible domestic violence abuse and to help uncover the problem and help reduce domestic violence across Maryland. And then the last program that the center is currently, the newest initiative is the Bridge the Gap program, which is aimed to expose students in underrepresented groups to a healthcare career. Obviously, maybe physicians because of that's our backing, but any healthcare career. The ultimate goal being that the healthcare in Maryland, the disparities lessen, and we get representation by all minorities, all parties, all races. Everybody's seen by somebody that looks like them. So that's Bridge the Gap. So in a very, in a way to bridge this, this discussion is focused on physician mental health, students' mental health, and the mental health of domestic violence survivors. So without further ado, I'd like to introduce our moderator for the evening, Mr. David Black, the CEO and co-founder of Cabana. And he will then be able to introduce all panelists. But thank you for joining us, and we're looking forward to a great panel discussion.
Great. Thank you so much, Alan. I really appreciate the thoughtful introduction and opportunity to be here today. As you mentioned, my name's David. I am just honored to be able to play a small role in the discussion, really kind of a unpaid tour guide, if you will, to just help shine a light on four incredible perspectives and individuals that are serving the mental health community from different angles. I am not a mental health clinician, so I share this though because I'm a passionate individual who has worked in healthcare, and I used to design benefit plans for insurance products and spent a lot of time looking at the mental health space. And I saw two things. I saw the challenge that we face from a professional level, a system that is constrained in the number of providers that we have, as well as in the mediums to access that care. And then to get paid appropriately also creates a cost challenge. There's so many areas as we think about providing appropriate, equitable, affordable support. But I also saw from a user-centered perspective, a latent demand. You can see data that shows 50 to 70% of individuals that never seek support. You see statistics anywhere from 9 to 12 years, depending on the diagnosis. It takes that long for someone to take their first step. We call that the treatment gap, but for many individuals, it is just the recognition of you not being ready to take a step. And we're here to continue the conversation because the more that we shine a light on the need, the areas of focus, the closer we get to being able to solve these problems. And so while I'm not a clinician, I'm someone who's passionate about this space, and so much that I quit my job and my wife let me start a company that is all about subclinical support, helping solve some of these challenges. And so I am just thrilled to be able to stand alongside four incredible individuals here as we touch a topic that affects all of us, that we are immune to no one. There really is no separation in our society that keeps us from mental health challenges. And so our focus today spans three distinct but very important audiences. We have healthcare professionals, the individuals are expected to care for others, who put themselves first, and in the helper professions, often have to make time to put themselves first themselves, but that's a struggle. We'll talk about students. We've all been there if we're not there already, and balancing the competing stresses of dealing with that journey, the future or unknown that comes with the journey, the pressures of navigating financial stresses, future careers, and uncertainty. There's a lot to unpackage there for anyone that's in that academic journey or considering it. And then the topic of survivors of domestic violence, a population that we hope to never have to serve, but until we're not there, we have a population that may be carrying trauma that's often unseen, and that bears a lot with that. And so three distinct populations that we'll shine a small light on today, and we'll hear from four incredible panelists who I'm going to not do a disservice by introducing them. I'd love for you all to each just share a little bit about yourselves and your story, and then we'll dive into the discussion. So going from left to right, I'm honored to be joined by Dr. Gail Jordan Randolph.
Good evening and welcome. My name is Dr. Gail Jordan Randolph. I'm a child and adolescent forensic addiction psychiatrist that has worked throughout the entire service delivery system in Maryland over many years. And I am here to talk about students in transition based on my experience consulting, certainly at the college level and through the public educational system. Thank you for inviting me.
Great. Thank you so much. Up next, Dr. Julie Brownley. Welcome.
Hey, thanks for having me. So I am a psychiatrist trained at University of Maryland, studied reproductive psychiatry primarily at Johns Hopkins in the residency program there, and founded a private group practice called Psychiatry for Women in 2022. This is a really special practice where we really focus on an integrative approach to treating mental health. So thinking about people from a 360-degree perspective, and bringing a lot to the table well beyond medication management. It's been a passion project and incredibly fun. And I have a very strong growing interest in physician burnout, and something that I focused on in residency as well. I also serve as a consultant for a large national telehealth company, helping to train nurse practitioners in reproductive psychiatry so that they can go out there and provide really amazing support to women needing mental health treatment. So it's been a blast.
Welcome. Up next, I'd love to introduce Lauren Dougherty.
Good evening, everyone. I'm Lauren Dougherty, and I'm the Training and Outreach Specialist with the Maryland Healthcare Coalition Against Domestic Violence. Also Program Manager of Domestic Violence Programming through the center. I've been working in the domestic violence field for over a decade now. I started off in the field working directly with survivors and victims, doing a lot of crisis intervention, until I moved into more of a training role, supporting professionals who are doing the screening and working with survivors. So happy to be with all of you here tonight.
Great. Last but not least, Ms. Audrey Bergin.
Hi, thank you. Thank you for having us. I'm Audrey Bergin. I am the Program Director at the Center for a Healthy Maryland for the Domestic Violence Services and the Operations Manager for the Maryland Healthcare Coalition Against Domestic Violence. I started my career as an art therapist, primarily working with children who
We may have lost a bit of audio for Audrey.
but sorry, my internet's a little unstable. I started a domestic violence program at a hospital and ran that for 20 years. So we intervened with people who were in the hospital and provided services.
Wonderful. So we have, I really appreciate you all just sharing a bit about your career journeys, because it is never as linear as it expects. And you often find you're pulling from those experiences in the work that you do. So we're going to talk through the various areas and topics that we have. We're going to go through, but beginning first with medical professionals and healthcare professionals. So as we do that, though, if you have experience that you want to bring to part, I'd love for our panelists to jump in and add anything here.
And I'll quickly add, usually this is done not by me, Lauren, I'm sorry. This is not something that I'm used to, but I do want to mention some housekeeping items that I didn't mention at the beginning. This event is recorded, and closed captioning is available to all participants. If you click the CC button on the bottom panel of your screen, there's more information on the center's programs, and the upcoming golf tournament is uploaded under the resources tab. So those are normally things that I don't have to worry about presenting to anybody. That's done by my wonderful team and my wonderful staff. It's a lot harder than I thought. So kudos to my wonderful staff for always doing the housekeeping items. But just wanted to make sure that was taken care of as well. Take it away, David. Sorry.
No. Fantastic. And please, Alan, if you have anything that you think about as it relates to the center's programming, feel free to jump back into the discussion. Would love to hear your perspective. So, all right, first let's actually go round robin on this, because everybody has such a broad perspective. And I mentioned the treatment gap, and I think of this massive chasm of support that is needed and support that is received. But I'm curious how each individual thinks about the treatment gap and defines this. And I'd love to, we didn't actually coordinate who should start first, but we're going to go backwards this time. So Audrey, if you don't mind opening us up with your definition of how do you think about the treatment gap, and perhaps how you've seen it be manifested in the communities that you serve.
Yeah, so I think the treatment gap is about the discrepancy around, who needs services, who wants services, and who actually receives it. And so for victims and survivors of domestic violence, I think there are some unique challenges that present in this gap. And one piece is this idea of medical abuse, that the abusive partner is able to prevent the person from seeking medical care or mental health care, that they will interfere with it in some way, that perhaps their insurance is actually their abusive partner's insurance. So if they seek mental health services, their abusive partner will know. The ability to afford therapy, we'll get into it a little bit more later, but domestic violence programs often have therapy, but there's often a waiting list, and the domestic violence programs provide it for free. But yeah, the ability to afford therapy. And then a big piece is the survivor's fear of, how their diagnosis could be used against them. So it could be used against them when the police arrive and their abusive partner says, well, she's got this diagnosis or he's got this diagnosis, and they're discredited. Or in the court system, they're discredited. Or that child protective services will be called because they have this, they have some mental health issues.
Sure. And you touch on affordability, and I can imagine within a student population where you're looking at student loans on the horizon, the thought of adding another car payment, if you will, for seeking treatment can be a barrier. Is that something that you think about, Gail, when you're thinking of the treatment gap itself as it relates to students, or do you define it more broadly than that?
That's a consideration as well. But when you think about the treatment gap as it relates to students, I think it's important to recognize, and I'd like everybody just to take a moment and think back to what it was like as a child. So for normal development, think about kindergarten. And remember when kids were walking in line and they had little cubbies assigned to them, and there was a lot of structure in the room. Think about first grade and second grade. Think about the time when you finally got a locker and that you could go to your locker unassisted. Think about transitioning in the middle school where you were allowed to go to classes unsupervised, but there was still structure. And as you think about high school, even less structure, and then transitioning into college. The gaps that we see are really particularly transitioning from high school to college. The gaps are certainly financial, a lack of financial understanding. Students sign loan papers and really don't understand the impact of the loan papers. Students are anxious, to get out of the house for a lot of different reasons. Particularly students that have been exposed to violence in the home. One of their motivations is to get out of the home. The transition to college is really complicated. There's a lack of understanding of how healthcare transitions from home to college and how to prepare for that transition. There's the stigma associated with transition. And in the reality, the lack of immediate access to care. So the lack of crisis services, crisis support services, and transitions contribute to the stigma, which also contributes to the gap. And the lack of funding for those crisis services also transitions. And then the student's role in the family. What happens when the student leaves? There's a separation from the family, and the anxiety, the family and the child's anxiety, particularly if a child is from a family where there is conflict, specifically emotional conflict, and some of the challenges associated with that.
Now, Julie, as we think through some of these topics here, where anything that you would add, just this treatment gap definition has many layers to it, some population specific, but some more broad. How do you look at this as a clinical provider helping individuals in counseling and therapy?
Yeah, I mean, well, thinking specifically about the healthcare professionals and what kind of treatment gap they're facing, it's pretty profound. Physicians are about 25 to 35% of them are experiencing anxiety, depression, and they have rates of burnout that are higher than a lot of professions. People will talk about 40 to 60%. So there's high demand for mental health intervention. The problem is only 30 to 40% of those individuals will seek care. And the reasons are numerous, but involve a range of things, including, I think, a big one being stigma. But then beyond that, really looking at some of the more system level issues in healthcare, ranging from like a fear of punishment, like from a legal standpoint, coworker shame, guilt, and financial limitations as well, because unfortunately, accessible mental health care really is it's a primary limitation in, I think, every demographic. So that is probably the best way of defining the treatment gap from the healthcare professionals setting.
Yeah.
And astounding implications when it comes to how this impacts healthcare in this country.
That's great. And we are going to dig into stigma a bit more, because there are different definitions of stigma itself. It is oftentimes a catch-all word, but you just cited so many different layers of the type of stigma that providers can face. So we'll put a pin in that and come right back to you here. Lauren, as you think about just adding another lens to the communities that you serve, anything else to add regarding treatment gap?
Sure. So you'll hear us talk a little bit more about this throughout the evening, but recently, Audrey and our program received funding to do focus groups with survivors to learn about what helped and hindered their safety in their situations through healthcare. And a lot of what we were hearing across groups, we talked to close to 30 people, and across 5 different groups, one theme that kept coming up was this idea that therapy was not accessible, either because the participants didn't know how to access it, or when they tried to, the resources were outdated, or there were wait lists. So I know Audrey talked about the wait list a little bit earlier, but absolutely, I think this lack of access to therapy services is a huge part of what we're seeing that adds to the treatment gap.
Yeah, great point. And as we get further through tonight's discussion, the concept of awareness, both self-awareness as well as just broader awareness of resources availability, feels like a topic that I'd love to hear each of your perspective on as we move further through this, because that is a drum that needs to be beaten around this. So let's flip back over to stigma and talk for a moment just about the healthcare professional workforce, because this is a community that we all interact with as patients, as supporting our family members, and you rely so much on the individual that is supporting you, and many times, just from a patient perspective, we just assume that that individual is stronger than us, and so that's not an honest perspective. But tell us more, Dr. Brownley, just about the healthcare profession, and when you think of the challenges that a healthcare provider faces, how does the system of healthcare make mental health support stressful? What are the forces that we don't see behind the curtain, if you will, that providers are dealing with day in, day out?
Yeah, I mean, so I just want to kind of lay the groundwork, because I think we probably all here have an appreciation for the role that medical professionals play in our day-to-day wellness. But I think a larger overarching issue would be on a national level, our medical and healthcare expenses are astounding, and our outcomes are quite poor. When we look at our country in relation to many others, including developing countries, we're losing the battle here. And the big question is why? And so, I would argue that corporatization of healthcare and the snowball effect that has really grown over the last many decades of venture capital and big conglomerates and work output driven metrics, EHRs, have really added a layer to this discussion that I think we should keep in mind. But as far as on the systems level, stigma in medicine is a big one, and we'll get to talk a little bit more about that in a few minutes. But in short, our medical culture has really set us up for sidelining mental health for numerous reasons. And I think some of them are pragmatic, and others are old holdovers, and others are financial, and really short short-term financial, not big picture long-term. The pressured work environment that a healthcare professional has to endure, and during it's not just that it's pressured, it's that many of the decisions that we make are going to be life and death decisions. And so in any given day, an ICU nurse might be making 10 different calls that could really make or break somebody's next several months of their life or next many years of their life. And so people feel that. And then they're working insanely long hours. And it's striking that, we've decided to cap the resident work week at 90 hours, and that we've decided to cap the number of hours in one shift to 36. What is incredibly striking to me, having left residency about 6-7 years ago and remembering this not too fondly, that they would offer you a ride home in a whatever Lyft, because they were so concerned that you might get into a car accident on your way home after a call shift. But not an hour prior to that, you're taking care of people whose lives may depend on your decision making. And may I add, they don't pay for your ride back to your car the next day. But really a shocking thing. How do we let that kind of paradox exist? The EHR and the burdensome documentation tasks that are now a part of, like, the daily lives of medical care providers, has been studied and identified as one of the top quality of life issues in the day-to-day. And then the chronic understaffing, which I think is sort of a vicious cycle that we're talking about. Like, people are burning out, they have anxiety and depressive disorders that aren't being managed, and people are dropping out of the workforce. And so then the teams are understaffed and morale goes down, and clinician shortages really just build the workload in ways. It's a vicious cycle.
Yep.
And so the attrition rates are astounding and very, very costly at that.
Is there, so I work with a chief wellbeing officer, or a number of chief wellbeing officers, but at one particular health system, they did a time study, and it's one of those histograms where you can see by hour of the day what that provider is doing and where they're spending their time. And when you look at the EHR activities, you have their shift, but then you see the evening hours of 7, 8, 9, 10, 11 o'clock. And the time they're spent, we call them pebbles. It's the pebbles in the work, the documentation, the EHR, but significant time sink outside and above and beyond what the individual may have signed up for. So
consuming, the documentation is so consuming. And I think even this sense that we're simplifying the EHR by creating templates and smart phrases and so on really only creates even more traps for us, because then we're clicking 800 different boxes. We're, sometimes carrying forward in dangerous ways because we're exhausted, because this is the 20th chart that we're closing, and it's 8:30 p.m. and we're trying to get home to kids or whatever it is, right? So I think that it's well beyond burnout fodder, but it's also this issue of safety, really. And I don't think we're bringing anything extra to the table. I think we're trying to prevent litigation, and I think we're trying to do a lot of what we say CYA. If you don't know what that is, it's cover your fill in the blank.
Good.
And
Yeah.
so they're doing a lot of that because, again, corporatization of healthcare really does sort of promote that kind of mentality that we don't want to we don't want to lose more money by not having every single piece in place. But it's not healthy for providers. We did a better job when we were writing paper notes that were simple. They were simple. They were notes that we understood. They were notes that our colleagues understood. If our colleague didn't understand them, guess what happened? We actually talked to each other. It's shocking, but the collaborative care model disappears when we're all relying on these garbage notes being passed back and forth that are really opaque and the clicking is the part that kills me. But everybody's kind of got a sense of what that burden looks like for them. And it really can stretch late into the night or onto the weekends. It's sort of the unseen hours that a doctor, a nurse, and other healthcare professionals face, physical therapists, right? Like everybody is subject to this who's doing direct patient care. It's hard.
You threw out so many different elements in the healthcare system, and thank you, because you think about just the hours and what you sign up for versus what is practice and expected. And there is that. And then there is likely a team dynamic that no one wants to be the weakest link. Is that another element in this too, that there's that norm around that?
Never forget. Yeah, absolutely. As a resident, sort of like this was pre-COVID, so it was fine to go into work very, very sick.
Yeah.
Totally sanctioned. Like you come into work and it does not matter how sick you are. You drag yourself in, and if you have a stomach flu, you might need to excuse yourself to the bathroom more, but you're expected to be there, and you're expected. And if you called in and said to your chief, "Hey, like I have this horrible stomach virus," either they actually are mad, maybe not the chief, but the team, right? Or you think they're mad because the culture is such that we all need each other to step all the way up and never be the person who fails your teammate. Not to mention, I think our profession as a helping profession really enriches for the people who want to be there for our teams and don't want to fail them. And so we will push ourselves, and it really is amazing. I take care of so many physicians and nurses who cannot see how much this impacts their sustainable commitment to their career, because in the short term, it feels so painful. The idea that I would have to step out for 2 weeks because my mental health has suffered to a degree that I don't feel I'm a functional or helpful part of the team, and I don't feel like I can make it through the day or take good care of patients or take any good care of myself, right? So if any of those things cross their mind, the first thing that they're saying is, I cannot leave my team because who's going to cover for me? How will they get by? And they're not wrong. We're so short-staffed that there genuinely is resentment that builds in these teams. If somebody does have, this situation where they're having to leave regularly, and they're having to, they're needing treatment or whatever it is, right? We are understaffed, genuinely understaffed. It's so high pressure. Everybody around us pretty much is subject to burnout. And what does that beget? We have compassion for our colleagues up until it starts impacting our own wellness. And then we want to be compassionate, but we're also experiencing the pressures and stress of trying to pick up the pieces. So we've really failed. Why is there not one more floating team member? Why aren't we, accounting for the very real possibility that somebody could be sick, or somebody might need a leave of absence, or somebody might go on maternity leave, God forbid. These things are just obvious. And as a means to cut costs or short-sightedness, we're sort of skimping on this support system that really should be there. We don't do it.
And Dr. Brownley, I think I'm only going to chime in when as David allowed me to, when I'm talking about the center's programs, and specifically what you're discussing when it comes to just the human element of a physician. And I think it's so important that people understand what our program is there for. It's for physicians. The physician health program is voluntary. It's for physicians that go through a lot of things that you just mentioned, and it's anonymous, and it's something that, physicians specifically should know that is available to them, because it is like doctors are human, and they have the same exact issues at home that I do. They might have a 2-year-old at home that has, the pediatrician calling them and saying, "Hey, come pick them up," but they are literally dealing with life in their hands. So it's a little different, and it's the strain of stress of having the importance of that role of a doctor, coupled with how the stresses of life really doesn't, it's a very finite thing. So I think, again, everybody that's watching, please understand that, Dr. Brownley, thank you for all of that, because that's exactly why we do what we do when it comes to the physician health program. We understand what doctors go through. We understand how important it is to have that equal balance. And if they do go through something, we're there to assist them. So that was great.
Right. And just to put a plug in for the program, and part of the engagement of the program as a committee member of the program, we can also help advocate. I mean, we're physicians, on the committee, and we can truly help support physicians as well as help advocate for them.
Yeah. Alan, please jump in as you have solutions in this. Dr. Brownley, there's so much in this that you're calling out, and it needs to be said, but we have to do the so what, which is what is there available for us. So
yeah, and there's a lot here, right? So I definitely have a ton of plugs at the end. There's a lot here that can be done. And I think sometimes we miss the mark. And other times we're right on the mark, and other times we're doing the right thing, and with a small tweak we'd really be making even more of an impact. So it's so important that people engage in these programs and help to identify spaces where things could be optimized for physicians in the workplace, because it's a huge demand, and we deserve a safe space to find help, anonymous help, right? Critical.
let's actually pull Dr. Jordan Randolph. I want to pull you into the discussion, because we should talk about stigma, and candidly, let's carry the conversation between healthcare professionals and students who are also going into healthcare, because that is also a very big struggle, particularly when you look at residents in kind of that second and third year as you start jumping into clinical rotation. So maybe just I'd love to hear, Dr. Brownley, when you think of stigma, help unpack what you were talking about, because stigma is a lot of definitions to it.
Yeah, I mean, and there's part of it that's hard to even put your finger on, because it's sort of this feeling, right, that we all have, that we have to hold and button it all down. There's this culture that we are inducted into in medical school, and it is you show up, you shush. You show up, you shush, you do everything you can to support your team without stepping on toes, right? You never no show, you never sort of like say, I can't, or I I'll never forget a situation where a nurse taught me the term how to say no by saying yes, because I held that on for the rest of my career. But essentially, we are taught not to say no, and no is a dirty word. And so we are, yes, I'm there. Of course I'm there. And again, as helping professionals, this is in part our nature, right? And then layer on top of it this internalized belief system that we are strong, we are the ones who take care of everyone else, and therefore we cannot be the ones who are weak. We cannot be the ones who are sick, because everybody is relying on us to say yes and to be there and to show up and to shut up. And
Yes.
it really is amazing how insidious this is, because and it almost comes down to not even being able to put your finger on it, because I think if you asked med students or residents, what is that? It's a little bit hard to encapsulate into words. Examples, there are a million, right? But what is it at its core? It's this culture that we are inducted into, that
Yes.
we have to stay strong, that
It
we
starts
cannot
early.
play weakness. Yeah.
And if I might comment, it's also conditioning. I mean, the path, the journey to a professional career, a professional medical career is a conditioning process. It starts with studying long hours in high school. It starts with test taking practice. It starts with, long hours in chemistry labs and physics and advanced courses. And you're expected to punish yourself throughout that process. And then you transition into medical school and you study, and then you do practicals, and then you study, and then you're transitioning into your early career, your internship, residency, and training. And if you show any weakness, you're shamed for it. Right? You're shamed for that experience. And then if you think about it, then there's this fear of confidentiality. What if someone
Which is
finds
real,
out?
which
And
is
sorry.
real, which Dr. Jordan is absolutely real.
Yes.
I mean,
Yes.
it is real. It is not imagined. It's
Yes.
spot on what you're saying. It's real.
It is. Confidentiality is a big barrier to accessing treatment.
Mhm.
And then in addition to that, when someone is at the point where they even acknowledge, because oftentimes what happens is people detach from that. So they don't see themselves as experiencing, the manifestations of depression, the manifestations of the anxiety, the manifestations of drinking too much. They don't necessarily see it at all, and they detach from it. And then when the question is raised and they're willing to accept treatment, nobody knows the telephone number. Right? And then if they actually find a contact and a telephone number, what typically happens is they make a call, it's an intake, and it's a scheduled appointment. That's why crisis support service is so critical, because they meet people where they are, they assess, they engage, and they try to support a transition, an immediate transition, not necessarily to higher levels of care, but just identification. Because a lot of times, if you can decompress, you can begin to have a discussion about what needs to take place, what kind of supports, what's available, how to access it. So confidentiality, shame, overwhelmed, unrealistic expectations. I just like to chime in and echo that the training is misaligned with physician expectations today. I don't think anyone trains young early career physicians to say, you know what, you're going to have to do charting and it's going to take you 3 or 4 hours post your clinical rounds to meet all the expectations of today's work. And we need you to factor that in.
Well, and I don't know if we would be going out on a limb to say, just for someone that is moving into the medical profession it is a journey that is longer than any other career journey. And even prior to getting into that graduate program, it's exactly as you mentioned, Dr. Jordan Randolph, that you have individuals who have been starting at an early age, have started thinking through that path. Some folks might wake up at 22 years old and say, I'm going to become a medical professional, but many have started their journey much, much earlier than that. And it is set in precedent, not only the work ethic, but is it fair to say you've got a mindset of your identity has been such as this professional that's on this path for some time? Does that play into this? Just the sense of who you are, you're part of this group. You've viewed yourself as that for some time?
Yes, and becomes a part of this expectation. The expectation is if I work really hard, now, once I finish my training, I will have more autonomy as an attending physician. I have more autonomy over my life. So I have to make this sacrifice now, and then I will have more autonomy over my life. The reality is that's no longer the case. Right? So you're now working, again, the expectations, the patient care, the clinical care, the administrative responsibilities, the coverage, the CMEs, the licensure obligations and following up on the licensure obligations, the student loans, the payments. Now you have to buy a house, so you choose to invest in your money, and all of this becomes cumulative. And then you add children, and you add other community responsibilities. It is overwhelming. But again, it's the expectation. If I postpone this gratification, then I will have more flexibility and I will be more gratified when I start my formal career as an attending physician.
That's great. I want to move to students and go ahead, Dr. Brownley, and then I'll turn that.
Sorry, I mean, yes, and to branch off from that, as you're moving out, right? And I care for so many residents and physicians in my private practice, and they're all saying, and I remember saying it too, when I get past this exam, then I'll be able to. When I get past this part of training, I'll finally be able to. Once I get my first job and it's secured, I'll be able to hit the ground running. Once and it was just, and I talk to my patients in the medical healthcare profession, you have to stop waiting to jump over the next hurdle, because guess what? The whole thing is just a series of hurdles, and it's all about finding some level of groundedness despite having one thing after the other. But we don't tell medical students, oh, by the way, this shelf exam is a drop in the bucket.
Mhm.
What's moving? And I think too, as a medical student, they are already savvy enough to know that getting support as a med student or as a trainee in residency, that their report of any mental health episodes or illnesses may impact their ability to get a license in their state or in surrounding states. And this terrifies them. And who can blame them? You've dedicated all of these years. You've worked so hard. You've put aside so much gratification to commit yourself to this career path. And then you find out that if you ever need help, this might be disclosed in a way that puts your license at jeopardy. How scary and how awful.
Mm-hmm.
And David, I know you're going to be going off of that, and you're absolutely right, Dr. Brownley. I think the reason I get to pop up on the screen and pop out of the screen is sometimes I get trigger words. So the trigger word that I heard was confidentiality. And confidentiality is a huge trigger word for me right now, and I think it's a huge trigger word for all three programs. And I think, with Lauren and Audrey, confidentiality of seeking treatment and understanding that, domestic violence victims having the confidentiality to know that they are in a safe space. But are they really? Do they think that they are? I would love to, David, not to take away from anything, but I would like to, confidentiality. I heard the word. I want to go to Lauren and Audrey in regards to confidentiality when it comes to domestic violence survivors and how they navigate mental health when it comes to going to physicians or having that trust. But that just trigger word, heard it, popped up on the screen, going back now.
Yeah, no, let's take a moment on confidentiality, because no matter what population you sit in, there are concerns about privacy. And it is, there's a statistic that I've heard just that says 70%, 77% of individuals are comfortable hearing that someone is struggling with a mental health challenge. We're okay with that. We feel we've normalized that, but only 40% are comfortable with that being that person. And so it's akin to, it's okay if you have an issue that you're going through, but if I have an issue, I'll be fine. I'm different. And there are real risks behind that can drive that. And so the confidentiality piece is just one component. This is a private, personal matter. So how do you see this, Audrey, playing out in populations where domestic violence is connected to this overall experience?
For domestic violence programs is even higher than HIPAA. We can't say a thing to anybody else without having signed written permission that's time limited and just for this one specific piece. And I think the piece, this has been a hot topic for Lauren and I, and with the Maryland Healthcare Coalition. In these focus groups that we did, confidentiality was the biggest concern, and it came up in every group separately. Almost every person experienced this. So they're being asked about domestic violence within earshot of other people, and they don't trust that those people may not, somehow know their abusive partner. That there were very few who were asked, but of those who were asked, was it half of them, I think, were asked in front of their abusive partner. So that puts them more at risk. So this idea of having privacy when you meet with a doctor, that, they're not going to feel safe saying what's going on if they don't have that privacy. And then the other big piece was around professionals calling Child Protective Services. So in every single group, women were saying, the vast majority of the people that we interviewed were Black women. They were saying, if I say what's going on, if I'm honest about it, I'm going to be labeled as crazy. They're going to call Child Protective Services, and they're going to take my kids away. And, Lauren, that's not just a perception. When you look at research around who is getting reported to CPS, who CPS is doing investigations and has findings on, who they are pulling, what families they're pulling kids out of and what parental rights are being terminated, there's a huge disparity for Black families. And Lauren and I, even though we know that domestic violence is not a mandated report, we know, we have heard healthcare providers say, as soon as I hear domestic violence and I know they have kids, I'm calling Child Protective Services, which is so damaging on so many levels when it's not meeting the threshold for the mandatory reporting law. Lauren, I don't know if you want to add more to that. That's been my, hot button topic for us.
Yeah, I think just to add that, we know that survivors of intimate partner violence are told over and over again by their abusive partners, if you ever tell anyone, if you ever talk about this, you're never going to see your kids again. Like these threats that they can then make real because of the way that practitioners are responding in these cases when they don't they're not meeting the threshold of that mandated report.
There's actually a comment that, and thank you all for putting comments and questions here. I'm seeing them as we're going through. So if you have feedback or questions, feel free to use the chat. They're coming through for us. A comment was made that says confidentiality might be the single most important part, in this case, of domestic violence because of the impacts it has. Dr. Brownley, you're talking about confidentiality being also really important in the healthcare profession. Dr. Jordan, confidentiality important at a student level. How much of this isn't confidentiality, but centers around trust at many levels? I see confidentiality as a component of trust. Is that true, Lauren, or do you see that as missing the boat, that it is really confidentiality?
No, I think that confidentiality is a huge part of building trust. You know, upfront, letting the patient decide what it is that they feel comfortable disclosing, you know, sharing what are the limits to confidentiality, what will happen next. I think a part of trauma-informed care is letting someone know what will happen when you share this information, and what, you know, what's going to happen in this appointment even. And I know one of the questions that we asked in these focus groups is, what are things that providers, healthcare professionals can do to build your trust? And it's things like being clear about what's going to happen. It's making eye contact, listening, active listening, following through. You know, we spoke to a survivor who had asked about a mental health referral and came back to her appointment, never received, you know, the email about this referral source, and then came back to an appointment with her abusive partner, and then it was brought up in front of her abusive partner. So then it put her in more danger. So following through is huge for survivors of intimate partner violence. And then also making time is the other big component that we heard, for the healthcare professional to sit with the survivor, sit with the patient, and make time to hear what it is about what's going on. And it sounds like, you know, based on the conversation from Dr. Brownley and Dr. Jordan Randolph, there's not a lot of time when you have all of those other responsibilities that you have. Audrey, do you have anything that you wanted to add to those pieces?
Not much more. I mean, the survivors we talked to were very clear about what they need, and having worked in a hospital system for 20 years and just having been to the doctor, like, yeah, I know it's, you know, this idea of making time. They were really clear that, like, sit down, don't stand over me, just have some conversation. So kind of building that rapport to be able to build the trust. But there was at least one woman who said, you know, after confidentiality was breached, and who said, I'm never going back to a healthcare provider ever again. It's, you know, just, they've really, really been traumatized by some of the systems that have betrayed their trust.
And from the healthcare perspective, from the healthcare provider's perspective, when you are in training as a physician, no one is teaching people how to meet people where they are, how to be in tune and read a room. I mean, this is not how we get in. We get in based on scores and resumes and research and building up all of these things that really have nothing to do with our capacity to sit down, meet somebody where they are, hear their story, and take a moment. It actually doesn't take that long. I mean, I will say our days are packed, but you can do this in 10 minutes. You genuinely can. I mean, you can't do the whole thing, right? But I think every social worker, psychologist, licensed counselor can attest to how, when trained, it doesn't take long to let somebody know that once you tell me this thing, these are the things that might happen. And when I'm here with you, I'm listening to you. I know you might not be ready for this. That's okay. Just sitting there with somebody and really listening doesn't take long. Doesn't take long, but that's not part of our training. And it's really a shame because we're missing the mark for women and domestic violence survivors. Really.
And why is that not happening? It's not happening early enough in school. Is it
It's not part
something?
of the training at all. It's genuinely not part of the training. I can tell you, motivational interviewing was the closest that we got to actually listening and hearing a patient and not strong arming them into doing what we wanted. And that was the first moment when I was in med school I learned about motivational interviewing and my brain exploded because it's obvious that you have to meet a patient where they are. And it's obvious you have to ask open-ended questions. And it's obvious that you have to provide people with options and tell them it's okay if you do none of these things. I'm still here for you. You can always come back to me. Why is that so hard that and honestly, what are Dr. Jordan Randolph, how many CMEs are we required to do on domestic violence? 10? Maybe it's state dependent. I mean, in total, I think I have been forced to do X number. Of course, I go well above and beyond, but shocked by the limited numbers that are required. And
Yeah.
these disparities exist all over medicine, but genuinely, and and Dr. Jordan, I don't know if you can speak to that from your perspective, but I don't remember ever getting you either can know to do that just naturally or or you don't and you don't get trained.
So part of the challenge is, if you look at healthcare operationally, I don't want to say assumption, but the theory is that by doing screening, then you actually screen for it. And if it screens positive, then you go to the next level. And screening is provided at all levels of care.
Mhm.
The problem is, we go back to that issue of trust. People are not going to share information on a screen with someone that they're not likely to see again, because who's doing the screening? It's supposed to be a healthcare professional, but who's doing the screening? How is it communicated?
Mhm.
And so that challenge is building trust, also creating the space and the opportunity to share. And then, as you said, meeting the member where they are, because just because they screen negative, in January does not necessarily mean that they will screen negative in March. But the screening may only be required once a year.
Yeah.
So I think that's another gap. We started talking about gaps. That's another example of a gap.
A
And
huge
I
gap.
just think it's also important to keep in mind, how much time does the average primary care provider spend in a visit? An initial visit, how much time is allotted? And a follow-up visit, how much time is allotted? Oftentimes, it can range between 10, 15, and 20 minutes. Is that
Sure.
enough time to engage someone that has been exposed to, or is at risk for, or is fearful of an experience that they are processing? So these to me are all very, very challenging areas. And I'd just like to also comment on, we've talked about domestic violence, but we haven't really spoken about domestic violence in the healthcare professionals, because that too is deeply shameful and deeply buried, and it takes time to establish trust
Yep.
and to allow the opportunity to share. But that is an area that I think we also need to consider.
Dr. Jordan Randolph, I think you've got an entire webinar topic on this. We talk through just the relationship, patient-provider dynamics, violence in the healthcare workplace. There is so much in that space. I want to let Alan make a note of this as a future topic, and if folks are interested in that, please let us know through the comments, because that would be a wonderful, wonderful discussion for us to hold. I want to shift to, Lauren talked about just trust more broadly and the provider's role in supporting trust and honoring that. But to your point, Dr. Jordan Randolph, you've got 10 to 15 minutes in many cases of the patient experience. It can't just be that one person's role for supporting individuals. And when you're a student, if you're struggling, it may not be that you're looking for a mental health professional at the start. That may not be your front door for mental health. And I know the center has a program focused on mentorship. I'm curious, where, in the context of mentorship, in the context of social support that we get more broadly, where can that play a role in the student population? But also, I'm going to come back to Lauren and Audrey as we think about the survivor population, as we think about healthcare professionals. Where else can we leverage a community of support and other support resources? So, Dr. Jordan Randolph, your thoughts?
Mentorship is so critical. It is absolutely, I mean, if there was one take-home message here, it is really creating a foundation and an opportunity for mentorship. And what's interesting is mentoring programs are really, I would say, I'm going to use the term facility, but when I mean facility, I mean college specific. They may have specific mentoring opportunities that are either research-based or not specialty-based, or whatever educational track a student is on, they may have an opportunity for mentoring. The challenge is matching students with mentors, and that also requires trust. And that may be optional. You know, in medical school, medical students, especially first-year medical students, are often assigned an upperclassman student that becomes their mentor to help negotiate the years of medical school training. And that also translates oftentimes in the training programs where they're assigned a more senior resident for mentoring, and particularly in early career physicians. There's an opportunity for mentorship and support. And at the same time, it is matching mentors with not just areas of interest, but personality styles, needs, interests. Part of the challenge is really matching mentors and giving our trainees, giving students the opportunity to change mentors. Oftentimes students feel like, well, if this is my mentor and I really am not connected with him, I can't change him until the end of the semester or the end of the year. You know, particularly in professional schools and engineering schools and architecture, schools of architecture, and the pre-professional careers. So sometimes there's a mismatch there, and there should be an opportunity to adapt and adjust to that. So mentorship is critical. And I'm going to broaden this discussion and say, not just to the healthcare professions. Yeah. You know, mentoring high school students, mentoring middle school students. That is such a foundation and such an opportunity to help guide their journeys, their professional growth, their personal growth. It is such an opportunity that we certainly can utilize more.
We do group-based work, and it's anonymous, but we're connecting folks in it. And self-doubt is one of the most common topics that we see individuals facing, that individuals want to hear through others that they're not the only one that's facing that. And ideally from someone that has walked a mile in their shoes and is maybe a couple steps ahead, you know, has gotten a pothole they've stepped in that they can point to. So that makes complete sense in the student population. I can imagine in the healthcare profession, you used to have
Yeah.
private practices that you might start under, and the starting points for healthcare have changed. But where, Dr. Brownley, where has mentorship or peer-based support played a role in your experience?
I completely agree with Dr. Jordan Randolph. This is one of our most powerful tools that we have. And I can speak both personally to my experience being mentored and being stuck in this weirdest mentorship situation that lasted for an entire year. And I thought, oh my God, who have I been placed with? What is this disaster? And I kept like whispering to my chief, and I'm not really sure this is the best fit. Hyper liberal, super conservative, like we had nothing. But that kind of matching is important. And now, as adjunct faculty at Hopkins, doing resident advisory and supervision and spending 6 months with a resident, I try to make sure that I'm being matched with somebody who's got similar interests and who appears to be somebody we could all gel together. But wouldn't it be great if we had a one virtual get together where we get to have breakout rooms and sort of just get a sense of who's who and what can I get? Because these are limited experiences and they're powerful, right? So I have residents that I supervised from years ago who cold call me, and I mean, millennials cold calling me saying, oh my gosh, you wouldn't believe what happened in this. What would you do? Right. So these are really powerful relationships that can build. And I agree that a lot of it comes down to really putting thought and time into the way that these programs are developed. But so key, people walk out with so much more confidence and they know that they have backup and support and that they're not alone.
Mhm.
We're going to take probably maybe 10 or 15 more minutes in this discussion just to cover a few other items, but I really appreciate all the comments everybody's been sharing. Audrey, as you think about your work and supporting individuals that are facing domestic violence, is there a role for mentorship or is it something different? What comes to mind when you think about mentorship? Because I'm trying to place it and I don't know that I can see it that way.
That's where the domestic violence program started, was with peer support, right? You had groups of women getting together to support each other back in the 60s and 70s. And then the field became more professionalized. So Lauren and I actually started a peer support group a year and a half ago or so. It came out of an advisory group with survivors who said, this is what we want. And even in our focus groups, which was just a one-time group with women who may or may not have known each other, some of them had been in shelter together, just being with other people who have experienced the same thing or similar things is healing for women. And the field has shied away from it, has been kind of fearful. They always want, or, oftentimes want a social worker in there, a mental health provider in there. But the women that we talked to in the focus groups, and we did a focus group on our peer support group to find out what's helpful, have all said talking to other people who have similar experiences that is really healing and empowering. Lauren, do you want to add to that?
Yeah, I mean, I think part of the magic of peer support, and particularly with survivors of intimate partner violence, is the power dynamic is taken out of it. So even, we try our best as advocates and professionals to make sure, we're doing everything to leave any sort of power dynamic out of that client professional relationship. It can still show up in a lot of ways. And so peer support can be really healing a lot, for a lot of what Audrey has already said, but also I think that can be a really important component of peer support, is people supporting each other who have been through it together. And there is no power dynamic in there.
Yeah, I have seen that, and it is something that when people have gotten it, it's there, but it speaks to some of the awareness challenges. Do people know what's available to them? Do they know how to find that? Are they finding someone that has that shared experience to them that they connect with? There's barriers there, and we've talked a lot about barriers here, and I want to flip this as some final thoughts and really go round robin on this. Beginning with you, Audrey, as you think through just the system, I'm going to give you a magic wand. If you can wave this magic wand and think of one change that you want to have in the system, where do you place that? Where do you invest and change this to ultimately strengthen mental health support?
Mm-hmm. I mean, I do think that the healthcare system is a great place to help people become aware of services. Pretty much everyone's going to access healthcare at some point in time. And, healthcare providers ask really personal questions that can be embarrassing and awkward. So what better place to ask about domestic violence and their relationships? It's a setting that provides for privacy. And by making that immediate warm referral. So when we do trainings, we encourage healthcare professionals to have, the local domestic violence program, trying to, create that collaboration so that straight from, a doctor or nurse saying, I'm worried about your safety, you don't deserve this, can be a really powerful message. Maybe that's the first time they've heard it. And, and I'd like to connect you with someone, bringing in an advocate right away to talk to them. I would go into rooms where the patient didn't want to talk, but they were willing to listen. So I was able to talk to them about dynamics of abuse and where they could go to get help and how they could get a protective order, things like that. And so I feel like the healthcare setting is a really powerful setting to intervene or to just even plant that seed, and to provide them with a resource so that when they are ready, they have some place they can reach out to.
Lauren, I'm going to switch over to you as well. On this thread or something different, you have a magic wand. Where do you see investing in our mental health support system to strengthen it?
Yeah, I mean, if I can just go off of I would say everything Audrey just said, I support all of that. And in addition to that, I think, and this kind of goes to the mission of Bridge the Gap, but more practitioners in the field that represent the population that they're serving. I think that's some of what we heard in the focus group, across the board in the focus groups. I think it goes a long way in building trust. And also healthcare professionals taking time to unpack their biases. And I think, around everything, but very much around intimate partner violence. And I think so many of us have had personal situations or know somebody personally who has experienced it that shapes our view around domestic violence. And so I think taking the time to unpack those biases before showing up in that clinical setting or medical setting with that person who maybe has experienced it is really important.
If I could add, because I think this is all so incredibly important, that we're asking the medical professionals to do training so that they're bringing their best to the table and escalating those CMEs that are going to help people to really start thinking about how can I show up for my patients that are enduring domestic violence. I think too, like you were saying though, this concept of interdisciplinary care is just one of the most incredibly powerful things that we could bring to the table for people who are victims, because what it does is it shows them that Lauren's here and we trust Lauren. And Dr. Brownley's here. And now we're starting to trust Dr. Brownley because Dr. Brownley and Lauren are in a loop and they know each other and they've connected about me and my progress. So now I'm starting to trust. That interdisciplinary approach brings so much to the table to build rapport and trust in all individuals at the table.
We see it even at referrals for finding a provider or specialist. We look at who we know, who we trust at that next level of support. So that's fantastic. Dr. Jordan Randolph, anything that you want to add as an investment? And I'll come back to Dr. Brownley if you have other pieces.
Absolutely. Crisis services, access to crisis services. We'll just start with Maryland statewide. I mean, we're in the process of building out crisis services in the state, but not only crisis services, but access to follow-up mental health services based on a crisis service referral within 24 hours. I hate to be so specific, but that's really, you asked my wish, can you wave the wand?
Your wand, I've given you the wand. It is yours.
Wave it for me and make it funding independent. That's my last ask. and then I'm happy.
I can appreciate that. Alan.
Well,
well,
so confidentiality was my first trigger word. Funding now is my second. So as executive director of the nonprofit, I can't not mention funding. And if I had a magic wand, I think funding our amazing programs, the reason why we do what we do is really would be my number one. Being able to, everybody that's a part of this discussion understands the importance of resources, and money is one of the biggest resources that is necessary to make sure that all these things happen. So funding would be my biggest wand. Being able to put as much funding to what Lauren and Audrey are doing to in their initiatives when it comes to prevention of domestic violence and understanding of domestic violence and giving back to those who have been abused would be huge. Students, same way. Funding is a huge reason why students currently, both in Maryland and nationally, are held back. That shouldn't be. And it shouldn't be the case, especially in America. There shouldn't be a case where some of the brightest students are held back because of where they live or a funding issue. And the same with healthcare providers. Funding debt, the amount of debt that, doctors go into, the amount of things that people, have that makes them do the things that they do, because if it was free, and it's, Dr. Brownley, it's great that, at least with Hopkins now, we've got Bloomberg coming in and putting a ton of money towards medical students, but that should be across the board. I know Harvard's doing it, but funding in general is one of the biggest things that's limiting us from doing things, especially when it comes to mental health. So I took the wand, all the funding, I'll take it all, and we'll make sure that everything, gets taken care of. So and I just really want to plug all of the panelists. Thank you so much. David, thank you so much. This has been extremely insightful. It's more than I imagined when we discussed doing this, and I can't thank you enough for agreeing to do this. I think, as you've seen from the comments, this has been extremely, extremely impactful, and I think everybody's taken a lot out of everything that you guys have said, and 100% myself. So thank you very much for tonight.
That's great. And anybody have kind of final thoughts? I have one extra wand to give if someone has a wish that they want to put out that they feel strongly about.
I have something
I'll
I
give you
read
two wands.
recently.
Right,
Rather than mandatory reporting, mandatory supporting. So if there's an issue that arises that, there's oftentimes things going on and the family needs support. So I really kind of liked that mandatory supporting.
Dr. Brownley.
Just, as far as ways in which to get involved, practical ways in which to get involved, if you're listening and you're thinking, how do I make a difference? We've already done the plug for Maryland Physician Health Program, which is a critically important program that helps to liaison and generate a system in which the punitive nature of support to physicians needing mental health care or rehabilitation in some way or another have been separated as much as humanly possible. And they're doing an amazing job of that. So getting involved in the MPHP, NAMI is another organization that you can get engaged in. And as far as physician mental health, Dr. Lorna Breen Foundation is another one that is doing some incredible work, and you can look at policies being proposed and get involved in trying to promote policy change through those organizations.
Thank you so much for sharing that. I think that's an incredible bridge to just us parting ways this evening. So the topic has covered so many areas, and these are 3 distinct populations, but just as a common theme, we talked about confidentiality and trust and the role that we have as individuals and peers in helping provide that trust to create safe space, but also as providers. So I appreciate the bridge that each of our panelists helped in connecting both the unique challenges, but also where we can see opportunities to make a difference. So for incredible panelists, Dr. Brownley, Dr. Jordan Randolph, Audrey, Lauren, thank you so much for your time, your thoughts, and going with the flow as we shifted around in the conversation. There are 3 incredible programs that we touched on that are rooted in confidentiality. And I know the center is going to be sending out communications. If you're not aware of these programs, please take a moment after this to learn about it in the email that follows, because if not for you, one theme that we've learned about this is trust can happen at any level, any relationship, whether it's professional or personal. And awareness is such a critical component of that. So being seated next to the person and you have the opportunity to raise your own awareness, you now are empowered to be able to support not just yourself, but those around you. So please take a moment to learn about these 3 incredible programs and share that. So that's my one magic wand wish for you all. So thank you so much for the evening and the opportunity. It's a joy and such a treat to speak with you all. So we'll stick around for any final thoughts, Alan, or next steps.
Well, I was going to say, since you're not going to, I'll plug David. Cabana is wonderful. Cabana, I've used the platform multiple times. It's, for anybody, it doesn't have to be a healthcare professional. Cabana is a fantastic resource to have for mental health, for self-help. It's just, David, you guys have done a great job. So I know this wasn't supposed to be a plug for what David also has going on, but it is, I can, if he's not going to do it, I will. So everybody look at Cabana as well.
Anyone that wants to talk mental health and innovation, I'm all up for it. So thank you all so much. It was a treat.
Thank you.
Thank you, everyone.